So our first speaker today, my name is Neela McAdapati. I'm one of the chief residents. Our first speaker is Dr. Finley Zachariah. He's the Associate Chief Medical Information Officer and Medical Director with Informatics and Value-Based Supportive Care at City of Hope. Dr. Zachariah is recognized as a compassionate and highly skilled supportive medicine physician, providing symptom management, pain control, and palliative care for adult and pediatric patients. He was recently named an emerging leader by the American Academy of Hospice and Palliative Medicine and is board certified in family medicine, hospice and palliative medicine, and clinical informatics. After earning his medical degree from Chicago Medical School, he completed a family medicine and tropical medicine residency in Whittier at Presbyterian Intercommunity Hospital, followed by a fellowship in hospice and palliative medicine at Kaiser in Los Angeles. Combining his training in tropical medicine with his humanitarian values, Dr. Zachariah has volunteered significant time in underserved parts of the world teaching palliative care and helping patients in Cameroon, Zambia, India, and Ethiopia. He currently serves as an Associate Chief Medical Information Officer, supporting his colleagues in the adoption of clinical technologies and refining the electronic health record system to improve healthcare delivery. His programmatic and academic focus includes tailoring patient care to individual values and goals, advanced care planning, and leveraging technology to enhance the coordination and delivery of patient-centered medical care in serious illness. Outside of work, he has been married to his wife, a hematology nurse practitioner, for 16 years. Together, they have 4 children ages 2 to 11. He enjoys spending time with family and tinkering around the house, from construction projects to home automation. Please join me in introducing Dr. Zachariah.
Thank you so much. Sorry for the very long intro. Can you see my screen here?
Yep.
Great. Okay, perfect. And this is going to be a rapid blitz fire presentation. I have about 20 minutes or so, but I'm happy to entertain questions and follow up after the fact. The following disclosure, and you'll also have all these slides as well too. So wanted to just go over 2 main topics for the group today. One was on an AI model that our team had developed here at City of Hope, helping to identify patients at high risk of near-term mortality. And then secondly, and more practically, how do we actually apply this in the care of our patients at City of Hope? So City of Hope, as you may know, is one of the NCI comprehensive cancer centers. We're a leader in bone marrow stem cell transplantation, having performed over 17,000 to date. It's a little over 110 years old in terms of an organization. And while we initially started out in Southern California, we're now actually a national health system with locations also in Arizona, Georgia, and Illinois. So just, thinking about AI, I think many, if not everyone, has heard about AI and just some of the inappropriate uses of AI, especially by insurance or by others thinking about, how do we ration care, for example. And so I want to start out with saying this is definitely not that. What were some of our motivations, as we thought about an AI model to help identify patients at high risk of near-term mortality? And so, some of that is that when you look at patient care, cancer patients oftentimes, receive a lot of care near the end of life that can be ineffective, costly, and misaligned with their goals and values. There's a number of studies nationally that show, patient preferences for, say, preferred location of death is actually at home. But oftentimes that's not realized, and there's a whole myriad of factors behind that. But just prima facie, there's definitely a disparity between what patients express that they want versus the care that they actually receive. We also know that it is going to take discussions and documentation of goals of care to be able to help make sure that happens, and we can by doing that reduce unwanted care. We also know that we don't have unlimited time, and we have a lot of patients, a lot of other clinical duties, and so because of the limited capacity of clinicians, how do we understand where can we be most helpful, as well as where can potentially palliative care help and be engaged. Also, with all the advent of the latest clinical advances in medicine, from CAR T cell to additional therapeutics, immunotherapies, etc., survival curves are actually changing, and so prognostication becomes a bit harder as time goes on in our field. And so we had asked the question, can AI help us with this? So we published a paper a couple years back, and we're going to actually be doing a follow-up paper here, hopefully in the next few months. But we looked at a comparison of the AI model as compared to medical oncologists in terms of prognostication. One thing I want to also, say outright is that it's not meant to work towards a state where AI replaces clinicians. Totally believe that AI should augment clinician decision making. But we had just done the paper in this way to basically validate how good or not was the model in comparison to current standards. So to give you some insight into the model itself, it's again a 90-day mortality model. So it predicts at the time, is this patient, whether solid or liquid tumor, able, or likely to die within the next 90 days. And here's a little bit more details around it. It's an XGBoost model. It takes a look at several different features in the chart, from demographics to labs, flow sheets, diagnoses, utilization factors. This is a little more granular insight, and again, just for time, I'm going fast here. But it'll take a look at things like lymphocyte percentage on the left-hand side, but then all the features on the right-hand side pertaining to that. So it'd be the lymphocyte percentage count within, and it takes a look at 180 days worth of data at the time that it's doing the prediction. So what is the count of lymphocyte percentages in the last 180 days, or the standard deviation of all the values, etc. And so, yeah, as mentioned, at least 2 encounters with the data, up to 6 months of data, and then it's both inpatient and outpatient. These are some of the most predictive features. So some things, make sense, but it's actually not really calculable by us as clinicians. For example, count of normal lab results was the most predictive factor, for example. And so it makes sense of how much is normal versus abnormal, but nobody is spending the time counting these features in the chart as we review patients. We'll skip through this, but there's been a lot of work done over the last several years around this. And so how did we do this study? So the oncologists were actually asking themselves a surprise question: would you be surprised if this patient were to die within the next 3 months? Brief background, the surprise question has been around for a long time. It usually is done at the 1-year time point, but it's actually been studied in terms of several time points, including as short as a week, and has been used in many different diseases, cardiac, renal, including oncology with reasonable performance. For City of Hope, we ended up choosing 3 months, mainly because we're also a quaternary referral center for advanced cancers. And when we talked to the medical oncologists, they said, if you ask us, would we be surprised if a swath of patients were to die within the next year? We probably wouldn't be surprised for most of our patients. And so then the discriminatory value of that question became much less useful for that team. And so at 3 months, you're then thinking about, are clinical trials appropriate? Is hospice appropriate, et cetera, which is why we ended up choosing that. And we incorporated into, we're not sure if University of Miami is doing this, but we have clinical pathways that basically say, for example, stage 1 breast cancer, this is the first line of therapy. If X, Y, and Z happens in terms of tumor markers, then there's going to be adjustments. So because we have that centralized, and we try and encourage that all patients are navigated, we were able to incorporate a mandatory question for any patient who had metastatic disease. And each time the pathway was navigated, then the clinicians were answering this question. These were answered by physicians and APPs. Data was available in the model or the warehouse, but was not available for the model in terms of analysis. And so what we ended up doing was, again, taking a look at all the surprise questions answered for an 18-month period between December 2019 through August of 2021. Sometimes there was late documentation, for example, in the pathways. And so we excluded any of those navigations by the clinicians or the surprise question prognostications. And then for the ones that we had left, we took a look and said, which of these surprise question answers had a model prediction in the 30 days prior to the surprise question being answered by the oncologists or hematologists. And what we came up with was 3,100 paired predictions on a little over 2,000 patients. Just so you see the days between the appointment for when the clinical prediction happened on the surprise question and the AI model was median of 2 days, and so it was generally pretty close across the board. So from a just brief statistical analysis, the surprise question is a binary yes or no, whereas the model prediction gives you a score between 0 and 1. And so we had to set a threshold to convert risk scores into decisions. We ended up choosing the threshold to be the sensitivity of the oncologists. And then we compared the positive predictive values to assess that. A very brief, just refresher for those who may be less familiar. In AI machine learning, people oftentimes use terms like precision and recall. Precision is the same thing as what we've learned as positive predictive value. So that means within an identified group of patients, how many true positive patients were identified out of all the patients identified within that sample that was flagged. Recall, otherwise, is the same thing as sensitivity, and that's also within the identified group. How many number of true positive patients were pulled in as compared to the true positives for the entire population. And so just to give you a very quick example of that, moved during the pandemic, got a koi pond out of it, learned all sorts of stuff. But say if we had an AI model that helped to identify how many kohaku koi are in this pond, this fish on the top right, you'd have a entire population. So this would be, this rectangle would represent the whole population of the koi fish in the pond. The yellow dots here represent the kohaku koi in this example, and the blue represent any other types of koi. And so asking those same questions, what's the precision? So the AI model comes up with this flag group on the left-hand side. So it thinks that of all the fish in the pond, the flag group on the left are the kohaku koi. But clearly you can see there's a mix. And so the question is that how good is this? So from a precision standpoint of positive predictive value, within this flag group, how many of the true positives are there as compared to all of those that are in the flag group? So you can see there's 5 yellow dots, 5 other dots, so 5 out of 10 is 50%. Whereas the recall or sensitivity is how many true positive patients are in the flag group as compared to all of the true positives in the entire population across the whole pond. And so there's, again, 5 dots on the left-hand side, 15 on the right-hand side, so 5 out of 20 is 25%. So I hope that makes sense. The prevalence also is important. And so how many are there? So there's 20 kohaku koi here, for example, out of 60, 40 other koi. So 20 out of 60 is 33%. And another performance measure that we found to be helpful, especially in low prevalence situations like mortality, is this precision to prevalence ratio. And so a precision to prevalence ratio of 1 is no better than chance. Just so you have that for a frame of reference. And in this case, it's 50% over 33%. So this is approximately 1.5. So, what happened here, basically, the sensitivities were matched. The precision for the oncologist was 34.8. The model was actually at 60%. So it was quite a bit higher. And then when you look at the precision to prevalence ratio that we just talked about, the oncologists were at 2.3. So they were definitely much better than chance. It was just the model for that same precision to prevalence ratio was at 4.2. So it was quite a bit better than the oncologist in this regard. So this is that same thing, represented visually. The AI model gives you an entire curve. We chose a specific set point based off of the sensitivity and then compared the positive predictive value on the y-axis. We'll again, just for sake of time, jump through this. We found a couple things. You can't treat all physicians as the same, right? You have different performances. So we ended up actually taking a look at every single individual oncologist performance. So that's what these dots represent. And then we applied it to the AI model. So you can see that the clustering is much tighter for the AI model as compared to the oncologists. The other thing that we took a look at was when within a 90-day span did the AI model actually outperform the oncologists. And so I would have thought that it would have been further out. But it's actually in the near-term mortality. So within 35 days of death, the model actually significantly outperformed the oncologist, whereas between 35 days and 90 days, there was equivalence between the model and the oncologist, which is interesting. several limitations. Again, would direct you to the paper for more interest, and happy to come back at some point if there's interest. So the question is, great, so what? We have a nice AI model. What do you do with that ultimately? And so, as part of the Alliance of Dedicated Cancer Centers, the Moffitt, MD Anderson, City of Hope, etc., we band together on different quality initiatives. And one of the things that we had done was this Improving Goal Concordant Care initiative that really wanted to align patient preferences with the care that we were delivering, and especially improve end-of-life outcomes. And so there was a enterprise-wide hematology medical oncology initiative over roughly 3 years that had these 4 components. First was communication training. Secondly was structured goals of care documentation. Third was having specific priority populations. And then the fourth was a measurement framework on how we did. Within the priority populations, we leveraged the AI model that we had developed at City of Hope, and then we also got clinical criteria from the hematologists and medical oncologists as well. So things like metastatic solid tumor with an ECOG of 3 or greater, for example, or the hematologist had shared with us, say, lymphoma or myeloma with 5th line of therapy or greater. So we were able to capture these things discreetly. We then were able to leverage different decision support tools within this. So we ended up bringing emojis to an EHR near one of our clinicians, sad faces, happy faces. We actually created a goals of care status column, which basically helped with high visibility in terms of which patients were identified as having a high risk of near-term mortality, but also didn't have goals of care documented and/or advanced directives or physician orders for life-sustaining treatment or out-of-hospital DNR forms on file. We also, had kind of operational goals around this and even incentives. And then we layered on top of that nudges. So this was an inpatient nudge, for example, that provided transparency. This model, predicted that this patient's at high risk of near-term mortality. Here's the top 6 factors for why, for example, this patient may die within the next 90 days. And then we had the opportunity for alignment. So it was, now, do you think this is bogus, or do you actually, agree with this? So that the clinicians can answer that. And then ultimately, what do you want to do about it? And so we provided them the tools to do it themselves. We created smart phrases that allow them to do their own documentation, provided them the billing codes that they can then get RVU credit for this, as well as the opportunity to engage the supportive care teams, whether it's social work or palliative care, supportive medicine. This is, again, just for sake of time, we'll breeze through this, but we had a pretty detailed note. So it covered things like the intent of therapy, clinician estimated prognosis, what was the prognostic awareness of the patient goals if their medical condition worsened, was prognosis explicitly discussed with the patient and family, as well as the recommendations and plan of care, and then ultimately the opportunity to, again, put the time and then support the billing. For the sad face, for example, to change to a happy face, the oncologist and hematologist actually had said, you know what, if this is the best national standard that the ADCC had come up with, let's go ahead and measure ourselves against all of it. So they actually had us build effectively. They have to fill out every single one of these fields for them to actually get credit, as compared to just a couple of them. We also did other things from an informatics standpoint. We made sure that anytime this documentation happened, it could be done within their workflow. So you don't have to create a new note or a separate note. You can just, within your progress note, consult, etc., use that phrase. It, through that same mechanism, automatically pulled it into a central area of the chart. And then we also wanted to leverage, patient-generated health data as well. So we built a My Chart questionnaire that was able to be sent out to patients that help to capture some of this information, as well as from advanced directives. And again, for sake of time, we'll breeze through this, but it's available in the deck. We also had nudges for other team members as well too. So social work, for example, they had our practice advisor BPA that said, this patient's at high risk of near-term mortality. They don't have advanced directives or pulse. Please engage with them to help capture that. And then we also, from an operational perspective, again, had our targets, but we wanted to, in some ways, gamify this as well as, help make this fun a little bit. So for Tableau, we ended up with the approval of our chairs. Actually, they allowed us to put their pictures on, the Tableau dashboard. How was the department doing? But then from a more specific perspective, we then said, well, how was each division doing? And then from a division perspective, you then actually had the performance of every single individual clinicians. So it actually created a lot of insight and transparency for the leadership to say, not only, we are either, here, for example, we're above goal or we need to get to goal and we want to beat the other department, but also, where do I need to engage my faculty specifically to help improve performance? And then just we were able to share this at the inaugural AI showcase for American Medical Informatics Association. Learned a lot, and from an outcome perspective, we were able to actually get thousands of goals of care conversations and a lot of the ACP billing codes actually done. And so, for example, last year we actually generated over $270,000 just in the ACP billing codes. So that was actually unrealized revenue that the faculty were, they were doing the work, they were having goals of care conversations, but they just weren't using the CPT codes. And the other thing is, from a patient impact perspective, we published in ASCO and have a paper coming out soon, hopefully, on looking at the heard and understood questions. So these are questions that the American Academy of Hospice and Palliative Medicine had recommended. They're not part of MIPS and MACRA from a performance status, and we incorporated in our PESC-GAINI surveys for the medical practice survey, and we found that there was a statistically significant improvement in our heard and understood scores for how patients saw the relationship with their physicians. So with that, it's possible, leadership matters. It definitely requires a lot of thought and design and tools, and it also requires some institutionalization as well to make this happen. And to end on a Yiddish proverb, better has no limit. So with that, it takes a lot of people, it's definitely not me alone, but thank you, and happy to answer any questions.
Dr. Zachariah, thank you very much for that chock full of information, condensed presentation. A lot of information there and a lot of valuable and important stuff that we're grappling with as an institution, as well as I'm sure Dr. Soares and Huber, who are on the call, can confirm. One thing, it's very interesting that you're able to look at it at the level of even the provider. The question I have is, how effective is this information in changing provider practices? In other words, what's the loop to feedback other than showing the picture of the division chief on the thing? How do you use this information to then change practice, and have you been successful in doing so?
Yeah, so a couple of different things. I would, in transparency, again, we did start this out almost as an accelerant, I'd say, to operational change with the institutional incentive program. So we did provide a bonus to clinicians, and we were very careful about what were we bonusing. So it wasn't that we're bonusing more people to hospice, for example. It was actually, we want to bonus you for doing the right thing, which was having goal of care conversations with patients. So we for the first year created a denominator, which was the patients identified by the AI model and then by the clinical criteria that the departments had chosen. And we then set targets, min, median, and max for performance. Last year, what we found for the first year was that we exceeded over close to 70% of the patients identified. The clinicians actually had goals of care conversations with them. But what we found was that sometimes, even if the model is right 70% of the time, for example, that means that 30% of the time it's wrong. And sometimes you might have late lines of therapy, like our lymphoma colleague said, light therapy, for example, is pretty common, but that's actually a distinct line of therapy. And so we might get to fifth line pretty quickly, so that might not capture all the right patients. And so last year we ended up choosing a target, and we said about 3,000 unique patients across the enterprise should have goals of care conversations. This was we basically took a FTE ratio to patients and said, roughly about 40 patients per FTE would be a good target to try and hit. And the departments actually exceeded that as well too. And so now what we're trying to do to bake it in, now that we no longer have an incentive, we've actually stood up a morbidity mortality conference for both heme and med-onc, focused on how do we think about improving systems and processes that can help to improve end-of-life care and minimize deaths in the hospital. And then secondly, looking at the quality of death as well. So that's actually been a highly attended forum by both medical oncology and hematology, where they then review their own cases, and we then are starting to share some of this data that's helped to move the needle, and we've definitely seen a lot more change from a practice perspective. And then just making it as easy as possible to do this. It takes less than 2 minutes to fill out one of those notes, and so that's also minimized the resistance to being able to operationalize it.
Any other questions? Otherwise, I have one I could ask. Okay, Mariana, Dr. Kawanda, do you want to ask your question?
Sure. Thank you so much for that excellent presentation. And thank you for helping me with ACP bookends many years ago, actually. We met on Zoom. My question is, were you all able to demonstrate any shift in hospital mortality metrics with these interventions? Is that something that you're looking to study in the future? Because I think that's a big motivator for many hospital systems. So
yeah, we're seeing some trends where we have to do the analysis, is it statistically significant or not? But even just the M&M forums, I would say, has been highly effective from that regard, where now 100% of the deaths, inpatient, are reviewed, and then we actually ask the hematologist or medical oncologist to present their own case to their colleagues. And again, not meant to be the surgical eviscerate yourself, approach that people are used to, but more how do you, again, think about this case, and then let's actually have a dialogue together about what could have been done differently. Did we actually have goal of care conversations? Did we know their preferences and values? Was the hospital the right place for them to die? Could we have done anything earlier, etc.? And then again, using any of those different elements to say, what system processes can we change to potentially make this better for the future. So I think that's been just that transparency, and then making it a safe environment has been also effective to help spark that conversation and the top of mind approach.
The reason for the importance and relevance for this for all of us on the call is that, of course, the ultimate goal is to improve patient care and quality. But as we look at rankings of institutions, mortality rate is considered one of the most important factors. And when you look at mortality rate, it's looked at differently if the patient passes away when they are in a hospice or palliative care environment versus when they pass away in the ICU on 5th generation chemo. So I think that this type of approach may be able to help improve things, but again, ultimately the improvement is for the life of the patient, not for the death of the patient. And I think, though, but the importance for all of us is to be able to understand this. And I guess these are EPIC related programs that are available, I presume, for the public, or are they proprietary only? I mean, we have EPIC, so are we entitled to, or able to purchase these add-ons, or is this something that was just research and done for you only, Dr. Zachariah?
Yeah, no, it is available from a commercial standpoint, but I would say, like any of the stuff within Epic, I would look to Mike. We both serve on the Palliative Care Especially Steering Board, and if you give him some IT bandwidth, I think any or all of it can be easily done. More from the AI model, I would say that's available, and happy to have separate conversations on that, but don't want to.
And much of these components are already in process, but I know we're out of time. Thanks, everyone.
Yeah, thank you, Dr. Huber. Thank you, Dr. Zachariah. Let's move on, Dr. Gaddafi.
Perfect. I'm very happy to introduce our next speaker, Dr. Julia Bini. She is an assistant professor of clinical medicine in the Division of Infectious Diseases at the University of Miami Miller School of Medicine. Dr. Bini earned her medical degree from the Universidade Federal de Minas Gerais, one of Brazil's most prestigious universities. She completed her infectious diseases fellowship in Brazil, initially focusing on the treatment of HIV/AIDS patients. In 2015, Dr. Bini relocated to the United States, where she completed her internal medicine residency at Mount Sinai Medical Center, followed by fellowships in both infectious diseases and transplant infectious diseases at the University of Miami Jackson Memorial Hospital. She has since joined the faculty at the University of Miami. Her clinical practice, as well as her educational and research efforts, focus on infections in immunocompromised patients at Jackson Memorial Hospital and the Miami Transplant Institute. Please join me in welcoming Dr. Bini.
Hi there, thanks for the introduction. Can you hear me okay?
Yes, we can hear you.
Okay, so I'm going to talk about Cryptococcus infection with a focus in solid organ transplant. I have no conflict of interest. Here are the objectives of this lecture. Number one, to identify risk factors and acknowledge the importance of early diagnosis of donor-derived infections. Number two, to review the epidemiology of Cryptococcus infections in solid organ transplant recipients. And finally, I'm going to review the management of Cryptococcus infections in solid organ transplant recipients. I'm going to start with a case. So the patient number one was a 76-year-old female with a history of preemptive deceased donor kidney transplant. She had an uneventful post-transplant period and was discharged home on post-operative day 5 with a working graft. However, she presented on post-operative day 51 complaining of weakness, headache, and shortness of breath for 3 weeks. She also noticed a papular skin rash to her abdominal wall for about a week. So I'm going to stop right here, and I would like to highlight that our solid organ transplant patients, they are at increased risk for infections in general. And some of those opportunistic infections may present with dermatologic manifestations. So when you come across a transplant patient with a skin rash, you have to keep your mind open and think broadly about bacterial, fungal, viral, and parasitic infections. And the list is pretty broad, as you can see in this slide. For these patients, it's always advisable to perform a skin biopsy. So that's what we did for the patient. We recommended a skin biopsy that was performed and showed numerous biting yeast forms of Cryptococcus species with thick mucoid capsule seen throughout the dermis. So she was diagnosed with Cryptococcus infection. She was started on amphotericin lipid complex and flucytosine right after the diagnosis was made. And she underwent workup for disseminated Cryptococcus infection. The serum Cryptococcus antigen was high, as you can see here. She had blood cultures that grew Cryptococcus neoformans. And then the next step was to do a lumbar puncture to rule out meningoencephalitis due to Cryptococcus. Even though the CSF analysis was overall unrevealing, the CSF meningoencephalitis panel came back positive for Cryptococcus species, and the CSF Cryptococcus antigen was high at 1 to 320. During the hospital stay, the patient developed intracranial hypertension requiring repeat lumbar punctures, and eventually she underwent a lumbar drain placement. She had a prolonged ICU stay that was complicated by kidney failure requiring renal replacement therapy. She developed chronic respiratory failure requiring tracheostomy and PEG tube placement. She was transitioned into hospice care, and unfortunately, she passed away only 3 months after transplantation. Who was the donor? So the donor was a 70-year-old male with history of hypertension, diabetes, and atrial fibrillation. The type of donation was donation after brain death, and the donor cause of death that was listed was cerebrovascular stroke. The donor was hospitalized for 11 days before he passed away. But when you look into that donor in detail, you find out that he was brought in by his neighbor after falling and sustaining a scalp laceration. but he had been complaining of severe headache for 2 weeks. Even though his CT brain was completely normal, a brain MRI showed a very small 1 centimeter acute infarct in the right frontal lobe. No lumbar puncture was performed, and the Cryptococcus antigen was also not performed. All the cultures that were obtained, including blood, urine, and BAL, came back negative. The patient declined neurologically during the hospital stay and was declared brain dead. So the clue for this donor is that his symptoms, severe headaches, and his neurological decline cannot be explained by the radiological findings. So the suspicion is that the donor had Cryptococcus infection at the time of death. So let's talk a little bit about fungal infections in solid organ transplant. As you can see in this graph, Cryptococcus is the third most common invasive fungal infection in solid organ transplant, following Candida and Aspergillus infection. The overall incidence ranges between 0.2 and 5%. Typically, this is a late occurring infection with a median time to onset ranging between 16 and 21 months post-transplantation. And how can Cryptococcus be acquired in solid organ transplant recipients? So there are 3 different ways. The first one is through reactivation of a latent infection after receiving immune suppression. Secondly, patients may acquire Cryptococcus through environmental exposure and followed by de novo infection after transplantation. So keep in mind that Cryptococcus can be found in the soil and in bird droppings. And the transplant recipients may inhale the fungi spores, and that's how the lung infection starts. Following that, you can see dissemination of the infection to different body parts, including the brain. And the third way of acquiring Cryptococcus in solid organ transplant recipients is when the donor has Cryptococcus infection or colonization at the time of death, and we call that donor-derived infection. In the United States, it's mandatory to report every suspected case of donor-derived infection. And the reason is because we want to evaluate the other recipients from the same donor and give treatment or prophylaxis to those recipients when indicated. Between 2009 and 2019, 58 reports of potential donor-derived Cryptococcus occurred, involving 58 donors and 180 recipients. And during that time, 12 donors were determined to have resulted in proven or probable transmission to 23 out of 34 recipients. More than one recipient from a common donor developed proven or probable transmission in 8 out of 12 reports. In that same report, they found out that donor-derived Cryptococcus typically occurs early, with most cases diagnosed within 100 days post-transplant, as you can see in the graph. And the mortality of donor-derived Cryptococcus is pretty high, with 5 recipients dying, which accounts for 22% mortality. So even though the donor-derived Cryptococcus carries a high mortality, I would like to highlight here that donor-derived cryptococcosis and donor-derived infections in general are a rare event. So just to put into perspective, between 2009 and 2019, over 270,000 solid organ transplant recipients were transplanted from over 101,000 deceased donors. During that time, there were 23 recipients with donor-derived Cryptococcus, which accounts for 0.01% of the recipients, and 5 deaths occurred. On the other hand, during that same time, there were over 75,000 patients who died on the waiting list. So the key message here is that even though we want to mitigate the risk of donor-derived Cryptococcus infection and donor-derived infections in general, on the other hand, we don't want to decrease the organ pool unnecessarily. In that same paper, they found out that most donors that resulted in donor-derived Cryptococcus infection died from CNS etiology, and about 1/4 of them had an underlying immune-compromising condition. So the key message here is that for donors with atypical neurological symptoms or symptoms that cannot be explained by the radiological imaging, or young donors dying from cerebrovascular disease, you have to think about Cryptococcus infection, and ideally these donors would undergo workup for Cryptococcus infection prior to being considered for donation. So when should we suspect a donor-derived infection? Initially for recipients with an atypical post-transplant course. So for instance, recipients with encephalitis, fever of unknown origin, sepsis of unknown source. But also we should think about donor-derived infection for recipients with early bacterial fungal infection, multiple recipients of organs from the same donor with the same infection, and finally, an atypical infection for the early post-transplant period. For instance, we know that for Cryptococcus infection, it's usually a late occurring infection. So if we come across a fresh case or an early case post-transplant with Cryptococcus infection, you should rule out a donor-derived infection. If you suspect on a donor-derived infection, you must report to the organ procurement organization and or to the organ procurement transplantation network within 24 hours. Again, the goal here is to offer prophylaxis or treatment to the other recipients when indicated. So this is a life-saving measure, so I cannot emphasize that more. And that brings me to the patient number 2. He was a 72-year-old male. He had history of preemptive DKT, and he was sent to the ED on post-operative day 58 due to donor-derived Cryptococcus infection in the kidney recipient from the same donor. His post-transplant period was complicated by a right testicular infarct that was related to a possible testicular torsion, for which he underwent orchiectomy. He was asymptomatic on arrival, and his kidney graft was working well. So he was admitted for workup of Cryptococcus infection. His serum Cryptococcus antigen was positive at 1/160. He underwent a lumbar puncture that came back completely normal with a negative meningoencephalitis panel and negative CSF culture. We requested pathology to review the testicle tissue, and there was no evidence of Cryptococcus infection in the testicle. His blood cultures were no growth. So he was started on a timely manner on fluconazole prophylaxis, which he's taking up to now, and he's doing really well. So moving forward to the Cryptococcus clinical spectrum, patients may present with meningitis, pneumonia, extrapulmonary involvement, or disseminated infection as defined by CNS infection or fungemia or involvement of at least 2 non-contiguous organ sites. Patients with meningitis normally present with fever, altered mental status, and headaches. Patients with pneumonia have a wide spectrum of clinical presentation that ranges from asymptomatic presentation to hypoxemic respiratory failure requiring mechanical ventilation. The most common radiological presentation is a pulmonary nodule, as you can see in this picture. In terms of the extrapulmonary locations for Cryptococcus infection, we normally see skin involvement, but we may also see kidney, liver, prostate involvement as well. I would like to highlight here that our transplant patients in 50 to 75% of the cases present with disseminated infection with involvement of the brain and lungs. In terms of the skin manifestations of Cryptococcus, our solid organ transplant recipients usually have the lower extremity involved in 65% of the cases. And the most common cutaneous morphology is acute cellulitis in the transplant group, which is different from the HIV population that we normally see umbilicated papules that resemble molluscum contagiosum lesions. Also important to know that the skin cryptococcus typically represents hematogenous spread of disseminated disease, which means that if you diagnose skin cryptococcus in an immune-compromised patient, you have to look for infection at other sites, specifically brain and lungs. How do you diagnose Cryptococcus infection? The better options, diagnostic strategy that is available is Cryptococcus antigen testing in the serum and in the CSF. I would like to highlight here that all immune-compromised patients with suspected cryptococcosis should undergo a lumbar puncture to rule out meningitis. And the reason is because a negative serum Cryptococcus antigen does not rule out CNS involvement. And here you can find the most updated recommendations on the treatment of Cryptococcus infection. These are the recommendations from the American Society of Transplantation that were published in 2019. I think it's important to recognize that there are no randomized controlled trials that have looked into the antifungal treatment of Cryptococcus in the transplant population. So the current recommendations are an extrapolation from clinical data from the HIV population and some retrospective data from the transplant population. The option of antifungal treatment varies depending on the extent of the infection. So for disseminated disease, CNS disease, or moderate to severe pulmonary disease, we do induction therapy with a liposomal formulation of amphotericin B in combination with flucytosine for 2 weeks, and this is followed by consolidation with a high-dose fluconazole and maintenance therapy with low-dose fluconazole for 6 to 12 months. For mild pulmonary disease, patients do not need to receive amphotericin B or flucytosine, and they should be placed on fluconazole low dose for 6 to 12 months. I would like to highlight this trial with the very exciting data that was published in 2022 in New England, the AMBITION trial. So this was a phase 3 open label randomized control non-inferiority trial that included over 800 HIV positive adults with cryptococcal meningitis residing in the sub-Saharan Africa. It compared 2 different induction regimens. So the experimental group received single IV infusion of high-dose liposomal amphotericin B at dose of 10 mg per kg in combination with 2 weeks of oral flucytosine and high-dose fluconazole. On the other hand, the control group received the WHO standard of care that at that time was IV amphotericin B deoxycholate, 1 mg per kg per day, and flucytosine for 7 days, followed by high-dose fluconazole for a week. Both groups received consolidation therapy and maintenance therapy with fluconazole. So the data showed the induction therapy with single-dose liposomal amphotericin B combined with flucytosine and fluconazole was non-inferior to the WHO recommended treatment for HIV-associated cryptococcal meningitis, and there was also less or fewer adverse events, as you can see in this graph, especially anemia and electrolyte abnormalities. Following the AMBITION trial results, the WHO updated the guidelines, and the 2022 guidelines on cryptococcal meningitis in HIV patients have incorporated the data from the AMBITION trial. And nowadays, the induction therapy recommended by WHO is a single high-dose liposomal amphotericin B with 14 days of flucytosine and fluconazole. So the question is if we can use or apply the data from the AMBITION trial in high-income settings like the United States. So there has been a lot of criticism regarding that because the control group from the AMBITION trial used the WHO standard of care at that time, which is different from the standard of care that we use in high-income settings. And also the HIV management and the management of increased intracranial pressure is different in the high and in the low income settings. But for the purpose of this lecture, my next question would be if we can apply the AMBITION trial results to our transplant population. And my answer to this question is that unfortunately, the AMBITION trial only included HIV patients and no solid organ transplant patients were included in that trial. So I don't think we can extrapolate that data to our population. But I would like to highlight that, you know, some people have been using, and there is a single case report on the use of single high dose liposomal amphotericin B as part of the induction, as you can see, just published this year and included only two transplant recipients. In terms of the management of Cryptococcus, I think it's important to understand that the management includes not only the antifungal treatment, but also other strategies. Patients with Cryptococcus meningitis, they develop a significant inflammatory response in the CNS, and that leads to elevated intracranial pressure commonly. And that can result in significant morbidity and mortality. So a critical part of the management of Cryptococcus meningitis is the management of the elevated intracranial pressure. And that's usually achieved with daily lumbar punctures until the opening pressure is normalized. Some patients may need the placement of lumbar drains or VP shunting placement as well. Also, for patients who are immune suppression, such as transplant recipients, it's advisable to gradually taper the immune suppression, but you should do it gradually. You cannot stop right away because a rapid reduction of immune suppression may cause the emergency of iris. Finally, I would like to comment on this paper that was published in 2023 in CID with very promising data on oral lipid nanocrystal amphotericin B for Cryptococcus meningitis. This was a phase 2 randomized controlled trial that showed that this oral formulation of amphotericin B had the same antifungal property or efficacy when compared with the combination amphotericin IV plus flucytosine. So I'm looking forward to hearing about the phase 3 randomized controlled trial. So in summary, Cryptococcus infection is associated with high morbidity and mortality. Prompt recognition and reporting of donor-derived infections can allow implementation of prophylaxis, which may avert disease in other transplant recipients. Combination therapy with a lipid formulation of amphotericin B plus flucytosine, followed by fluconazole, is the preferred treatment in high-income settings. Data on the use of induction therapy with a single high-dose liposomal amphotericin B combined with flucytosine and fluconazole in high-income settings and SOD recipients is limited. Consult ID early. Thank you.
Thank you, Dr. Viotti, for that very interesting presentation. I learned something. When you see a benign CSF, it doesn't mean that the cryptococcal antigen is not present. So that's important to know. It would seem to me, given the expense that's done for all these solid organ transplant patients, why not screen, and maybe you said this, but why not screen every donor serologically prior to removal of an organ, just to prevent even one infection? Or is that not cost effective?
I don't think there is data in terms of cost effectiveness. I think we would run into false positive tests, which would probably be an issue and would decrease the pool of organs. That would be a problem. The recommendation is to do workup for Cryptococcus in the donors that have anything in their history that suggests Cryptococcus infection. That's what we do. But at the end of the day, the donors, they normally come from different centers. We accept or not them here in our center, and sometimes doing or not doing the Cryptococcus antigen is at the discretion of the treating physician at the other center. When we get involved, when they call us about the donors and we have questions related to that, we normally request to check the donor for serum Cryptococcus antigen. Sometimes we even demand them to do a lumbar puncture prior to accepting or declining the offer.
Thank you. Well, I want to thank everybody for coming today. Our prayers are with, of course, our families and friends and neighbors on the west coast of Florida.